Hi, good evening, dear colleagues, dear speakers. On behalf of the Emirates Society of Ophthalmology, today we are presenting our second webinar in 2021, and it will be about dry eye. As we used to say, dry eye is dry subject, but we'll try to take it from different aspects this day. We will have today Professor Maurizio Rolando from Italy, Professor Maurizio, Associate Professor, University of Genoa, and he's the father of dry eye diseases in Italy and in Europe. Today we'll learn a lot from him, and we'll have also my colleague, Dr. Osama Jaledi, consultant ophthalmologist, surgeon of cornea and refractive in Moorfield Eye Hospital, Dubai. And we will have, for the first time, Dr. Athir Al-Ansari, consultant rheumatologist from MedClinic Abu Dhabi. And with you, Dr. Omnia Hamam, head of the Scientific Committee of Emirates Society of Ophthalmology, and consultant in Zayed Military Hospital and Sheikh Shakhbout Medical City. So we'll start now with the Professor Maurizio Rolando to talk about the dry eye disease. Yes, Professor.
Thank you. Thank you for the presentation. Today we start talking about the changing landscape of dry eye disease. And well, the definition of dry eye disease is, pointing out how the disease really is not a tear problem. It's an ocular surface problem. And it's an ocular surface problem with involvement of the structures of the ocular surface, and it's characterized by inflammation and problems of the nerves conduction and symptoms. So we have a tear instability which will involve the ocular surface and provide changes and reaction of the ocular surface. And it's a rather prevalent disease. The prevalence varies from 6% to 25% according to the different studies that have been made. But just to say, it's really prevalent. It's a kind of a modern disease. In fact, our lifespan is increased, and we see that the disease will grow with the in the older population. So it's a disease which we have seen the last 10 years exploding, at least in Europe, with a lot of patients asking for help. And of course, there is a lot of patients which has not been diagnosed around. And this is becoming a kind of recognized public health issue. And another point is very useful to make is the difference in estimation of the impact of ocular surface problems linked to dry eye into the life of patients. As a matter of fact, there is a feeling that the ophthalmologists do underestimate the disease if, compared to the feeling of the patients. And of course, the symptoms, we all know them. It's very varying depending on the cultural, quality of the patient and from the environment of their life and what they're doing during the work, and many aspects make the feeling and the perception of the disease variable from patient to patient. And of course, what we don't think enough is dry eye is a disease involving the vision. It involves the quality of vision. It will involve what is called visual fatigue. People working on the computer or reading a lot or driving all day, and then they will feel visual fatigue, and visual fatigue is strictly connected to tear film instability and the impact that the instability of the tear film has on the quality of contrast sensitivity and vision in all. And of course, it's important because we, as surgeons, we have the risk of measuring the intraocular lenses not precisely if a patient has some, dry eye problems. So especially if we want to put a premium lens correcting astigmatism, it's mandatory that you have a good tear film in front of the eye. And of course, the involvement in contact lenses and in the compliance on medication is also important. And we will see this later on. And dry eye symptoms are all day and every day. And this is important for the patient because you have pain and irritative symptoms. We said about visual performance, the patient has a perception that their vision is not the one it used to be, and they become worried a little bit what's going on and if what will happen to me in the future. And of course, they start to feel they have a disease, and this will affect the general health. So this is because the dry eye is a chronic disease. And we will see this later. And in a study we did a few years ago, what happened that we asked the patient, do you think it's a disease, it's a handicap, or just a pure discomfort? And up to 20% of the patient told us that dry eye is an handicap for them, meaning that they want to do something, they have to do something, and they cannot do it the way they want because they have dry eye. And also this will affect the mood of the patient. And this other study I find very interesting because it says that among all the eye disease, the one with the highest prevalence of depression is dry eye disease. I thought it would have been, macular degeneration, and so instead, the study showed very nicely that dry eye is impacting on the quality of vision or the perception of the self of our patients. And this is a very interesting study. It's a study that says, how many years of your life will you give away not to have the disease that you have? And they studied a lot of disease. And what came out that moderate and mild dry eye has the same level of moderate and mild angina, and severe dry eye has the same score of severe angina. This make apparent the difference of perception that we have of the patient of dry eye and the perception that the dry eye has of this quality of life. And of course, this is another study. I think the data are becoming a little old. They say we use more time on our digital media than sleeping. And this is the reason why we are showing nowadays a change in the kind of patient that we see. Usually our dry eye patient is a female in what we say perimenopausal age. Now we are seeing younger people. Most of them are multi-screen users and contact lens users. They will add, and you see a younger group of people with dry eye in the asking for help. And of course, we said that dry eye is this is a point of view, say, of the doctor. A dry eye will affect the outcome of the refractive surgery, will increase the number of complications after any kind of ocular surgery, and of course, we all know the problems linked with the perception of our cataract surgeries because they have dry eye. There are reports suggesting that there is a higher percentage of regression after LASIK for myopia, and hyperopia also. And of course, we all know the problems that we have in convincing our patients that, you know, our FACO was uneventful and went out very well while they are feeling disturbance because of their dry eye after surgery. And the patient with dry eye is a patient with the risk in entering into a vicious circle. And all these, you know, stimuli that we get will, you know, push the patient inside the circle, but because of the ability that we have to adapt, we can come out. And our therapy should be aimed to prevent the patient to enter in the circle or remove the patient from the vicious circle as soon as we can. And this means that we have to be very quick in recognizing a patient with dry eye, which is really very simple in this system. You check risk factors, you listen to the symptoms, and you look at the surface of the eye. If you see a dirty tear surface, a very thin meniscus, hyperemia, MGD, this is the first step to, you know, raise an eyebrow and say, we are having some problem, and then stain. If you don't stain, you don't see, you don't make, you know, your diagnosis. So you can use fluorescein for the cornea, and lissamine green I highly recommend for the conjunctiva. Then check the ocular surface sensation and look at tear film turnover and clearance. If the sensation is okay, see the clearance, and that it's very easy to check. You just have to check the removal of your staining from the lower meniscus after 7-10 minutes after your staining. And if you see some lissamine green or fluorescein there, well, check the patient again. He's having a low clearance rate, and he has a high risk of having inflammation after surgery, for instance. And okay, you see here a list of the possible risk factor for dry eye. They underline the medication. We don't ask for medication enough, and a lot of patients after 60 years of age, I tell you by experience, well, they use a lot of drugs, and the combination of drugs can be very effective in reducing tear production and tear stability. So you check for the exposed area, you check and see if you see some dirt or some, something floating on the tear film. In the example you see here, this is mucin, which is not able to rehydrate and stay on the film. This is enough to say, yeah, this patient has a dry eye. And of course, don't forget to push on the lids to see the quality and the quantity of the available meibomian gland for this ocular surface. And then you stain, you check for tear stability, and you check the conjunctiva. You see this patient, it looks like being rather wet, and no big problem that I see, but I do lissamine green staining, and there is a lot of staining in the conjunctiva. And this patient, as a matter of fact, it was a Sjögren patient. And if I didn't do the stain, my way of doing the diagnosis would have been very, very difficult. And of course, you can produce your Schirmer test, mostly because the rheumatology will ask for that, but it's very interesting. But what I do prefer is to look for the tear clearance. That's very, very interesting, especially before doing any kind of surgery on the ocular surface. And there is something very useful to approach the question about inflammation, because many times the inflammation in a dry eye doesn't make the eye red. So if there's a lot of inflammation, of course, you see a red eye, but many times you cannot show, is there inflammation there? Well, we did, and it has been confirmed by other studies, that there is a strict correlation between the amount of lissamine green staining of the conjunctiva and the expression of markers of inflammation on the ocular surface. And of course, whenever you're talking about a patient with ocular surface disease, please take into consideration there are 5 pathogenic factors that should be explored and validated. The first one, instability of the tears and the quantity of the tears. And then you have to assess the amount of inflammation that you can see or you can suppose and look for. And then the epithelial malfunction and damage. The epithelia of the ocular surface are, secretory epithelium. So the first thing that happens, that they lose their secretory ability and they lose the function. Then there are other two things, which are lid margin changes and functional changes of the nerves, as well as maybe anatomical changes of the nerves, which are maybe the results of the previous 3 pathogenic factors, or are the starting point while we have the disease on the surface. So these 5 points are the target of our diagnosis. There is no sense in saying you have a dry eye. What does it mean for your surface to have a dry eye? Do you have a lot of inflammation? You have damage of the epithelium? This is what we have to do when we do diagnosis. And these 5 points are the points we have to treat in order to improve the quality of life of our patient. So let me finish thus, pushing in your mind that dry eye is very often a chronic, but it's a progressive disease. So it's worthwhile stopping the vicious circle as soon as we can in order to provide the patient for a good quality of life and interrupt the chronicity of the disease. So thank you for your attention, and let's have a shift to more practical, directly practical conversation. And I think the next talk with Dr. Hamam. Is that correct? The name? I'm sorry for giving my.
Yes,
is that correct? Your name?
Yes.
Sorry. So she will be talking us about glaucoma and the problems of the ocular surface. Thank you very much.
Thank you, Professor, for this nice presentation. And I'll share my screen first. You can tell me it's okay. Share. It's okay? Yeah, okay. Okay, you have my screen, you can see it, yeah? Yes, you have my screen. Okay. So I'll talk today about the ocular surface disease and glaucoma, double the trouble. And actually, it's the main trouble in our daily clinic. In glaucoma, actually, the glaucoma patients, they are managed by the glaucoma specialist, and all the ophthalmologists, they are seeing glaucoma patients. But actually, what we are looking for is something different than what the patient thinking about during the consultation. We are giving more time to the patient for the visual field, the optic disc, mainly for the ocular pressure, if the pressure is controlled. And we keep talking with the patient about the pachymetry sometime, about the visual field and how they did it, while actually we are speaking different languages. The patient, they understand one thing, that it's hurt and they don't feel comfortable. But not all of them, they come and say it loudly, because either they are afraid from telling them that they using or they don't use the medication, or we take them to the other surgical option. So the chief complaint, the main complaint of the patient, I can tell you that the patient, they say it during the consultation, but we don't give a lot of attention to what they are saying. It's hurt. When I use my glaucoma medication, my IOP is okay, but when he stopped the medication, the eye is better, he feel better, but the pressure is higher. And also many of them, they keep saying that they have blurry vision and itchiness when they just put the drops. So we need to give more attention and more time to this main complaint. Here actually I found a review of 720 papers talking about glaucoma and the ocular surface disease. And they found that 59% of the glaucoma patients, they have significant ocular surface disease. And 49% of ocular hypertension patients within the first 5 years, they use second medication, and in this way they start to develop ocular surface problem. One of the nice findings also I found it that topical glaucoma medication can cause burning, irritation, itchiness, and maybe the mild symptoms start to appear within the first 3 months of starting the anti-glaucoma agents. Maybe I'm sure that all of us, even me, we forget a lot to ask the patient if before starting the medication, if they have already ocular surface problem. Maybe Dr. Osama, he will talk later on after me, the cornea specialist or the refractive surgeon, they used to ask this question before doing any corneal problem or refractive surgery if their patients, they used to have dryness. But the glaucoma specialist, maybe we forget this point. And as I said, many of glaucoma patients managed by general ophthalmologists and by all the subspecialty. So I think we used to forget to ask this important question, that the treatment now, we prescribe treatment for glaucoma, and actually we will make the ocular surface worse. Here another paper published in 2010 by Finchner, and he said that they found on 600 patients, and they found that the ocular surface disease index, which is a questionnaire actually about the signs and symptoms, that 48% of the glaucoma patients, they have moderate to severe ocular problem. And here also another paper done on 101 patients, and they found 59% of patients, they suffer from ocular surface disease. Of course, the ocular surface disease with the glaucoma, it will impact the quality of life. A patient who has a lot of drops and he has irritation, for sure he suffer a lot, and on driving, in his work while he's working on the computer, and also there is correlation between the severity of glaucoma and the severity of the ocular surface disease. What's the main problem we have, or the main complaint? We have to hear it well. The congested red eye, allergy, dark CERN, the darkness around the eye, the severity of the itchiness, and the number of drops. This is the main complaint of the patient. It's not the visual field. It's not that the ocular pressure is high. It's not that the corneal thickness is less or high or thick. And this is the manifestation of ocular surface disease. Actually, those the patients, we are seeing them every day in glaucoma clinic. More than, and here in our country, we have actually a huge number of ocular surface disease and corneal problem, maybe because of the weather. And we have a huge number of patients who come with the red eye, eczema, blepharitis, dry eye, and actually what we used to say, oh, it's too bad, but you have to continue your medication, because if you don't continue the medication, you will lose the vision, so the patient will continue to suffer and will continue the medication, or he will decide to stop everything. And actually, how we can manage this patient. And this actually the circle, what we used to do. And this is our daily practice, which is not the right practice. Patient is uncontrolled, his pressure is uncontrolled, we'll give him anti-glaucoma agents. He's not tolerating the medication, so we will add anti-allergic, we'll add lubricant, we will add steroids, and we will add one more drop because he's not controlled with all those medication. So he cannot put all of them, or he will put all of them, and he will come back with again high ocular pressure, and we increase the drops again. These photos, actually, I took it from half clinic, 4 hours on Thursday. Those are my patients, different patients, just to show you that in half clinic of 10 patients, like 70% of them, they have ocular surface problem. And all of them glaucoma patients, all of them on medication. So now from our clinical practice, what could be the cause of this severe irritation in glaucoma clinic? It's the duration of therapy, the patient, they were longer time on medication, or the preservative or the active ingredients and the drops, the number of drops, the severity of glaucoma, that our patients, many of them, they are elderly population, pre-existing ocular surface disease. Actually, all those are the causes. And all of them, the conclusion is the toxicity. What we are using of medication, even the steroids and the non-steroidal anti-inflammatory and the natural tears, all the drops together with our drops of glaucoma drops, is just toxic to the ocular surface. And there's many studies and many papers show that they studied, actually they took the conjunctiva, apart from the conjunctiva during surgeries, from the patients who already used a lot of anti-glaucoma agents, and they found that they have a lot of macrophages and the goblet cell decreased, and they have severe and sick conjunctival epithelium and also corneal epithelium. So here another paper published in 2009 showed that the correlation between the number of medication, the more number of medication we have, more bottles we have more severe ocular surface. So 40% of the patient, they have severe ocular surface disease who are already on 3 medications. So as I said, what gives us this problem with glaucoma drops? So we said the number of drops, and also the active ingredients in the anti-glaucoma agent. The prostaglandin has higher prevalence and severity on the meibomian gland dysfunction. So just I'd like to summarize this point. So for all the colleagues, they will just maybe will have clue when we have a lot of medication giving it to the patients. So the prostaglandin affect maybe, or the most which affect the meibomian gland. Beta blocker act on the beta receptors on the lacrimal gland, of course, and reduce the basal tear turnover rate. The timolol alter the mucus composition and the tear film and increase staining of the cornea and conjunctiva after 1 month of therapy. There is a lot of papers published regarding this topic. The alpha adrenergic agonist, the brimonidine, significantly is the higher anti-glaucoma agent which give allergy and the least tolerated by the patient. Ouch. I cannot change the slide. Yes. Yes, this is the next slide. Okay. Now we'll come to the very important part, which is preservative versus alternative. One of the main cause, for me, I will say that this is the most important problem, or the most important cause of the ocular surface disease is the preservative. The preservative, we have the benzalkonium in all the drops, and for patients who will use it, which is we need it, of course, to keep the medication clean. The patient will use it for longer time, and it's extremely toxic. There is a lot. Before, it was already the first preservative approved by the FDA, and it's existing since 1930 or 1940. So since longer time, it was used in higher concentration. Now all the laboratory, they're trying to use it in lower concentration, as it's toxic. Of course, for glaucoma patients who are using anti-glaucoma agents for a long time, it's extremely toxic on the ocular surface. And what's the alternative exists now? We have the polyquad. We have the purate, which is oxidizing agent, which we can find it in the new bromonidine. The polyquad also we find it in the travoprost, the new travoprost, and the Sufzia, which is not available here in UAE. I think it's only in US. And there's a lot of papers published and showed that those preservatives are affect the ocular surface in less term, or it's less potent on the ocular surface than the benzalkonium. But still, most of the drops contain benzalkonium. Of course, the other option, which is the best option, the preservative-free, but because of the cost and also the availability, it's not available everywhere, and there is a lot of molecules still, the preservative-free, it's not exist. We have another problem here, the generic anti-glaucoma agent also, and there is a paper published in 2012 by Kahook et al. Showed that the temperature, the room temperature, or the exposure to temperature on the end of label value lead, it will significantly decrease the concentration of the active ingredients, and also the pH and the generic, it's higher in the generic drops. Yeah. We talk also about the old patients who put the drops beside the eye and put many drops at the same time, and the drops just will be around on the lead, and 2-3 drops inside the eye, so the quantity also increased here. And those are the worst patients we are seeing. I'll talk now about the other side effects which affect all the glaucoma surgeon here. That this bad ocular surface, its correlate with has a significant correlation with the success rate of our surgery post-operatively. So congested eye like that, we are not happy to go with patient to the OT. The conjunctiva is so fragile, very difficult to be sutured. Post-op, it will heal in very bad way, and we need really to treat the ocular surface, and we have to think always how to treat the ocular surface, and we have to think that if we have advanced patient or patient who's not controlled since the beginning, to start on to treat the ocular surface as we are treating the glaucoma. We have to do the both at the same side. And seriously, today maybe I'm here not to show or to teach you something new, but really to learn from the professor and from the speakers today who knows better than me in ocular surface. Because me myself, I found myself lost with such patients, and how can I manage this ocular surface for the patient and also for my surgical outcome. So now the diagnostic testing to monitor the ocular surface. As we are taking care of the glaucoma part, maybe we are not using those forms, which is the questionnaire forms, the ocular surface disease index and the glaucoma also form, quality of life form. Those forms It's actually a questionnaire about the signs and symptoms, and the higher OSDI values, it's mean the worse ocular surface disease, and it's the opposite for the glaucoma quality of life. The lower glaucoma quality of life is the worst ocular disease. Corneal stain, put always drop of fluorescein and stain the cornea, stain the conjunctiva, and check the conjunctiva. The hyperemic conjunctiva, this is something which I used to do always, because this it will affect, I know, the patient who is in pain will not be serious to use his medication. And always I'm thinking about second option. Breakup time, Schirmer test, try to do it, and check the meibomian gland dysfunction. It's very, very, very important. Yes. Now, what's the treatment? I will just try to put the treatment from my point of view. I will try to learn more during this webinar today from the experts. As glaucoma specialists, I will say that we have to avoid the preservative as much as we can. We have to avoid the generic. Lubricate with unidose, lubricate without adding any more preservative to the and the drops. So lubricant has to be systemic actually for all the patient with the anti-glaucoma agents, and it's better to go for sodium hyaluronate, I think, in my opinion. And topical cyclosporin, it shows actually a good effect for the patient post trabeculectomy. So also think about it. Non-steroidal anti-inflammatory, and always try to find the non-preservative version from everything. Vitamin A and carbomergel to relieve the dry eye symptom and to increase the conjunctival glob cell density. Also the new drugs, I will talk about them, which is will decrease the time of and the amount of the back use. Surgical treatment, also I'll talk about it now. The SLT, selective laser trabeculoplasty, which can replace medication. MEGS, glaucoma surgery in general, can avoid us or can protect when we have ocular surface or patient who cannot tolerate the medication. So don't go and don't lose the time by spoiling more his ocular surface. With surgery or mixed surgery could be helpful. Punctum plugs, I used punctum plugs for some patient who has significant dry eye. Those the devices which are available, not available still in UAE, but soon they will be available. Those are sustained release glaucoma drugs, which we can put them in the punctum or under the conjunctiva, which might solve the problem. As I said, the surgical treatment, the MEGs we have now, 3 or 4 types of MEG exist in UAE, which we can use them. So just think about that. Think about the laser trabeculoplasty, which can save the ocular surface of your patients. Here I'll go fast through some of the recommendations. The Canadian Society of Ophthalmology recommend to minimize the number of medication, and they showed that it improved the adherence and minimized the ocular surface side effects. The European Glaucoma Society recommend that the ocular surface should be evaluated and considered in the clinical management of patients with glaucoma, and in case of ocular surface disease, preservative-free formulation should be considered. Fixed combination medication also recommended by the European Glaucoma Society, not as first line of treatment, please, but actually it will reduce the side effects and reduce the number of drops. Also, European Glaucoma Society considered the laser trabeculoplasty as first line of treatment in glaucoma management. So my conclusion here, reduced number of drops, use fixed combination, preservative-free agent if available, back-free, benzalkonium-free medication, avoid generic, and support the ocular surface. Thank you so much, and I'm so excited to learn more from my colleagues. Thank you so much.
I think now, if you have any question, please write the question down the question and answer box that you find on your screen. And so we can have a discussion if you have time at the end of the presentations. May I introduce now Dr. Osama Giledi, who is going to talk of ocular surface management before, sometimes after, okay, refractive surgeries. Please, Dr. Giledi.
Good evening, everyone. Thank you, Professor. And thank you, the Emerald Society and Novartis. Can you hear me well? So I'm talking about optimizing your refractive surgery in ocular surface disease. About refractive surgery, usually when we're talking about refractive surgery, usually refer to corneal laser refractive surgery and phakic implant. But cataract and refractive lens exchange now considered as refractive procedures, especially when you consider about the premium IOL and toric IOL. So it's not anymore like just to do cataract, but it's become as a refractive procedure. I need to think about it. Ocular surface is really a very delicate structure. It's the proper function depends on all the system around it. From the lid should be normal, bubonic gland secretion. The type of blinking should have a normal blinking, not just partial blinking, and the frequency of blinking. Lacrimal gland should be healthy. Conjunctiva, goblet cell is very important. Corneal cessation is very crucial in the equilibrium. Tear film and ocular surface. All the ocular surface, the problem is vulnerable to our environment and all that can have effect in our tear film stability. When you look into ocular surface disease, usually mainly you're looking about the dry eye disease, bubonic gland disease, but also there's anterior basement membrane dystrophy, pterygium, Salzmann. All this is we face as ocular surface disease, which affecting our refractive procedure, and we need to deal with them. As you know, the versus cycle, all we know about it. Contact lens, usually many of our patients who wear contact lens, they become contact lens tolerance because contact lenses start to inducing their dry eye, and that's why they're coming for us to have refractive procedure. But also remember that laser surgery itself and ocular surgery, that also can cause the dry eye and make the versus cycle for dry eye with all other components which can interact to cause more dry eye in the versus cycle. Ocular surface, as you know, is the very important ocular surface as refractive part of the eye. It's contributed about 2/3 of the total refraction power of the eye, and really is very important because it influences the accuracy of keratometry, especially for cataract, the accuracy of our refractive, and that's very crucial for refractive surgery, and also can cause even additional abbreviation, contributed to the comfort of the surgery and the vision. So it really needs to be treated before and after the surgery. Biometry, as you know, is very crucial for our calculation for cataract surgery to have a patient who's happy patient with aim for good refractive outcome. Example for eye master, they have like a tear spot. If you had the tear film normally is like 4.79, but the tear film thickness that really change a lot and become much thinner when the dry eye, but also irregular. So that if you look to the mirror and what we measure with the keratometry, the spot is not accurate positioning and faded, so that will give us inaccuracy in the anterior surface astigmatism and also in the average KRD as demonstrated by different study, and can be a big difference in the calculation up to half diopter. So it's very important to treat that. There's one study looking to effect of levitographs on refractive accuracy and the symptom of dry eye for a patient who underwent cataract surgery. So it's 100 patients who had the course of levitograph 28 days before surgery and also after surgery. And in this study showed that the predictability is much better in the patient who had treated their dry eye before the cataract surgery. So they have more targeted, the aim of the refraction is much target, but also showed that high order of aberration is much less in the patient who has treated with levitograph. So levitograph in the studies shows significant improvement in the preoperative corneal surface measurement and also the dry eye in a different level like corneal staining, ocular redness, and tear breakup time. And there's another study also showed that is the high order of aberration, it's higher in the patient with the dry eye. So it's really very important if you consider using a wavefront treatment as a base for your laser vision correction. So the measurement you measure in the wavefront will be accurate, and the result will not be good for the patient. Look into the prevalence of dry eye meibomian gland disease in cataract patients. As you know, our cataract patient usually elderly patient, and this risk of meibomian gland function dry is very high. One study shows 75% they show sign of dry eye. Majority of them, 86% of them, they have meibomian gland dysfunction. The other studies show 69% of our patients coming for cataract surgery, they have meibomian gland dysfunction. So the prevalence of the meibomian gland dysfunction dry is very high for cataract patients. Also for refractive surgery, who's people who become intolerant to contact lens. So when you have the patient coming for you, you're very important to assess him, ask him about the history of dry eye, and they can have different symptom description, burning, soreness, foreign body sensation, fluctuation vision, which is very common complaint, I find it. But also ask them about if they have started to have dry with contact lens, because sometimes I ask them straight, you have dry? I said no, but ask them specifically with contact lens. You find many of our patients, they're coming for laser vision correction. The main reason they come to us because they start to have problem with the contact lens dryness. And this patient really, that dryness is just started, so be careful about them. Ask about the frequency of dry eye using, ask about dry mouth, if they have Sjogren syndrome. While they ask the patient about the history, it's nice to look to his blinking. Is he blinking normally? Is it a full blinking or partial blinking? I always give the patient questionnaire about dry eye for people who come for laser vision correction, and ask about the medication like antidepressant and Accutane. I found that a lot of our patients here use Accutane, and this is one interesting study show how affect the Accutane in our meibomian gland dysfunction. And the meibomian gland, after a month to 6 months, the meibomian gland become atrophic and reduce in the size and become blocked. And it take up to 6 months for the meibomian gland to back to almost normal, although sometimes doesn't go back completely to the normal. So very important to address patient who Accutane, and definitely, as we know, that we shouldn't do any laser vision correction. Someone uses Accutane, and we need to wait for 6 months before considering any laser vision correction. As we know, the tear breakup time is really one of the crucial tests we need to look to it. It's a very simple test. You just use a fluorescent staining and look to it. Nowadays, you can use the machines, what you call non-invasive breakup time, which even give you more reliable, more consistent. So patient, when you use a placebo, you see distortion of the rings, and that's a very good sign to measure the breakup time. Lipid flow is another modality which can use it. We can assess the lipid layer thickness, and they give us more quantitative assessment of the tear film of the patient. Staining is very crucial, because that's if you put a fluorescent and you feel stain or lissamine green, that is very good, because that's a staining is really it's a sign there's inflammation and you need to be addressed and need to treat this patient. Schirmer test is very easy to perform, although sometimes not always reliable, but it's a good test if you want to have more documentation and give you more idea about water component of the tear film. Color topography is really very crucial. Now, it's very useful to detect ocular surface. So when you ask the patient, when the patient comes to assessment, if the technician do the OCT, that if you look to the rings and if distorted, that's a good indicator. And if you see that if the patient with bottom slide, that patient with the dry eye, you see the mirrors completely distorted, but after a month of the treatment, the ocular surface become much smooth, and you could see the rings very regular and unique. So it's really a very good tool to diagnosis, and also to help us to see that the patient is now stable and you can go ahead with laser vision correction. Osmolarity, if you had access to osmolarity, is a good test to do. As some clinic do it routinely for every patient coming for laser vision correction. And other things, inflammatory dry, which is measure MBB9, is really very good, because if it's high, there's the inflammation, and that you need to treat this patient. Although the problem with it doesn't give you the quantitative measure of inflammation with the current inflammatory drive available, but it's a very good test. So color topography not only give us tear breakup time, but also we can see the tear meniscus, but also some of them, they have mammography, which you can see using infrared light to see the meibomian gland structure itself. So it's a very good test to give you a very good idea about the meibomian gland. But don't forget that when you have the patient, very important not to jump straight to the cornea. Always stop, examine the lid for the meibomian gland dysfunction, what you call before peripheral blepharitis. It's under diagnosis, I think. And it's very important to look lid margin, it's hyperemia around, and in consistency and the quantity of the meibomian gland secretion. As you know, bubonic gland dysfunction is very common. It's always associated with the dry eye. There's many contributor factors like age, hormones, systemic disease, Sjogren, Stevens-Johnson, psoriasis, atopy, polycystic ovary, hypertension, all can be contributor factor. Patient with an iridia, they can have bad bubonic gland function, even the children. So if anyone had an iridia, always check their bubonic gland function. They may have much more symptom of that. It's people had chronic blepharitis, contact lens wearer. People had lid tattooing. Some people, they have very bad bubonic gland function because of the reaction from the tattooing, and the people had all trachoma in the past. Always when you look to the lid, always look to the if there's any dermatitis and acne rosacea, and as I mentioned about Roaccutane use, it's very important to address it. Many of our patients coming for refractive surgery or cataract surgery, when you look to the case, if you're very careful, you could miss what you call anterior basement membrane dystrophy. So it's very important to look to the epithelium of this patient, because really it will affect the refractive power of calculated for the surgery. You need to inform the patient that this condition can get worse after surgery, and it can be affect the procedure itself. So anyone had anterior basement membrane dystrophy, you really, if it's moderate severe, always avoid to use any premium IOL for this patient. Even if you do normal surgery, cataract, this patient can have a symptom of recurrent corneal erosion at the side of the corneal incision. Definitely you should avoid LASIK for this patient, because they will have bad post-op vision outcome and they have recurrent corneal erosion. Always consider BRK for such patient if they want other laser vision correction. And sometimes if it's moderate severe, maybe you need to consider two-stage procedure where you treat you remove the all loose epithelium, you do BTK, allow it to heal for a few months, then to do BRK after. Some people, if it's a very localized area, some people use diamond pair for that. But it's very important to consider it and not to miss it when you do any refractive surgery. The other things, you could face a patient with pterygium. This is one of my patients coming for pterygium, but he had also coming for cataract and pterygium. And it's very important to do the pterygium first, because the refraction outcome can be completely different. So it's better to avoid do any combination pterygium and cataract. So do pterygium first, restore the ocular surface, and you could see in the topography down, the irregular stigmatism, it's completely flipped after the surgery. So this patient before the pterygium was 5.2 astigmatism. At 1.4, it changed to the horizontal meridian. And if you look to the biometry, this patient emmetropic lens was 21 if we did the calculation and base our calculation if we do combined surgery. But once you do the pterygium and excise after 3 months, the lens is completely different. So if we did straight away, we ended with a not good result, refractive error. The other things we face in ocular surface is Salzmann nodule. As you know, Salzmann nodule can affect significant refractive and can change. It's very important to educate this patient, because people with Salzmann nodule, usually they have a chronic ongoing ocular surface disease, and they need to be treated well with like artificial tears, cyclosporine, levetograph, or steroid or azithromycin. It depends on the severity of the ocular surface disease of this patient. And remember, it can recur after. So always need to treat this Salzmann nodule before any refractive surgery, because it can progress. But also, the measurement of refractive error is not consistent, so it will have surprises and regular stigmatism. So always treat it first, then allow it to settle. Always better to do BRK than LASIK for this patient, and to treat their dry eye. And always you need to use mitomycin C to prevent the recurrent, and also to prevent the scar, because they tend to have more risk of haze than the normal patient. Going to laser vision correction, which is the most common procedure we do for refractive surgery. All of them will affect ocular surface disease, from surface laser, BRK, LASIK, or SMILE. All of them, they have some impact of ocular surface disease. The LASIK, traditional microcatop is not a good option at all. They have more risk of corneal abrasion because of mechanical movement. It's the more deeper meniscus flap, so it's more risk of dry eye. So always, if you do LASIK, I think you should do femto laser to have precision, dry eye less, and also less corneal abrasion distortion. As you know, corneal innervation is very important. The cornea is the most innervated ocular surface in the body, and the corneal sensation is very crucial to maintain normal corneal physiology, normal blinking, normal tear secretion, and the neurotrophic production. So it's very crucial and very important. When you do surgery, we disturb that. Dry and refractive surgery, usually we refer to laser vision correction. it's usually we attack the cornea by the surgery, like for LASIK or even SMILE. We cut some of the nerve, we're creating some inflammation. So always we're exaggerating what we call pre-existent dry eye disease. So always need to look after the eye, you need to detect it, you need to prepare the corneal surface. And it's very crucial really to inform the patient really. It's just always very important to tell the patient you're going to have dry eye, especially patient who have dry eye, you need to inform them that will get worse, it will take up to a year to get better. Unless you tell that, really it will become very hard to explain to the patient after surgery when he comes with more severe dry eye. The other thing is LASIK-induced neurotrophic epitheliopathy, as is very common for the first few months after laser surgery, but can take up to a year and be even rare. By doing laser surgery, we're cutting and disturb the corneal sensation that reduces the blinking, reduces the tear breakup time, and that's disturb the ocular surface. So reducing the production of neurotrophic factors that will allow defect in epithelium healing and slow epithelium healing and will cause neurotrophic keratitis. It's very common. I think we underestimating before. It's as we said, it's related to disturbing cutting to the corneal nerve and result in the postoperative dry eye symptom like fluctuation of vision, reduce the best corrected and corrected visual acuity, patient complain of irritation, pain, and punctum corneal erosion, and the patient should have much more symptom. Regarding risk factor for dry eye for laser vision correction, the most risk factor really, anyone who had pre-existing dry eye, they're much more risk factor to have more dry eye after surgery. Elderly age, female, people who with contact lens use, systemic medication, people who have lid lag, doesn't close their eyes, or people who is diabetic. There's a lot of consequence of dry eye in the visual outcome. As you know, when you're a normal patient, the tear film is stable, they have very good quality of vision and stable. Every time we blink, there's tiny variation in our refractive errors, like 0.1 diopter, so it will not affect us. But in a patient with unstable tear film, that refractive error can be fluctuating up to 1 diopter, and that will make the patient complain of fluctuative vision, blares, glare, eye fatigue, and high order aberration. So the quality of vision is not good. And the study looked at the regression after LASIK. It's much more in dry eye. So 27% patient regress compared with just 7% regress in a patient myopic have LASIK surgery. So dry eye can affect even the regression for our patient. And that's really part of it because of inflammation. And one study looked into the effect of anti-inflammation after LASIK using topical cyclosporine, and they found that cyclosporine topical promote and expedite visual recovery and stability in patient after LASIK and PRK. The other study also looked into the cyclosporine and has been shown that enhanced axis regeneration after LASIK surgery. So patient with cyclosporine treated after LASIK surgery, the corneal sensation return quicker and they have less distortion and less dry eye. And that's, I think, is even Lafita and steroid, all anti-inflammatory, it can have that effect. It's not specific to cyclosporine, it's more related to reduce the inflammation and allow the recovery of the nerve fibers to the normal after surgery. As we know, in the nerve fibers plexus, it will affected by any cutting in the cornea. It's more affecting by LASIK than SMILE, but most of the nerve fibers can grow back to normal within 6 months to a year. And that's the dry eye will tend to improve by that time. Due is a guideline about how to diagnose and treat the patient, and the first one in the column look into a patient who's asymptomatic, but when you examine them, they have a sign of ocular surface disease. This patient need to treat it if you're planning to do any refractive surgery. What to do before surgery, as we said earlier, it's very important to restore the tear film stability, integrity of ocular surface, because the better ocular surface before surgery, the better the outcome. And you need to treat this patient, usually artificial tears, that's one of the main treatment, but you also need to educate the patient about improve the environment, humidity, avoid the draft. If there's inflammation, you need to treat the inflammation and always focus in the lipid layer, because really most of the patient, they have more symptoms because of the evaporative dry eye than aqueous deficiency. As I mentioned, artificial tears, the mainstay. There's different composition nowadays available, most of them using hyaluronic acid, but also consider oil containing emulsion with the meibomian gland dysfunction, but very, very crucial to avoid the preservative, especially the back, with all artificial tear. Inflammation, especially with meibomian gland disease, you need to treat it, either with steroids, cyclosporine, tacrolimus, levetograph, azithromycin, tetracycline. As you know, steroid usually we use it for a short period of time, but because we worry about risk of pressure, cataract. Levetograph is a moderator. One of the advantages really I found is it tends to be faster effect. So the effect of it is quicker than cyclosporine, and that helps us in our patient compliance, especially patient come for refractive surgery. That will help this patient. Punctum plugs, it can be used temporary for short period after the surgery for people that have very severe dry eye after, but you shouldn't use it for pure meibomian gland dysfunction dry eye because that make it worse. And anyone had inflammation, it's always better, you need to treat the inflammation first, control it, then you use the punctum plugs. Regarding the thermal pulsation procedure, LipoFlow ILX is both of them is using the heat and mechanical massaging to the lid to improve the meibomian gland dysfunction. Both they have FDA approval, but it doesn't last. You usually need to repeat it 6 months or 12 months, but you need to do it with other medication. It's one study looking to the 6 weeks prospective randomized single mask study looking to levetograph solution versus the thermal pulsated procedure, LipoFlow, for the treatment of inflammatory meibomian gland dysfunction. So patients who are coming for treatment, so they have a course 42 days of levetograph, and compare it with the other patient who had the LipoFlow, and the LipoFlow treated patient didn't experience significant better outcome than any one of the symptoms and the criteria than the levetograph patients. And the conclusion that anti-inflammatory treatment, levetograph, significantly improved patient symptom and sign compared with the LipoFlow, and the levetograph should be considered if there's inflammation, meibomian gland dysfunction in any patient with meibomian gland. Intensive pulse light is another modality I use it, which is really using a burst of light with specific wavelength. The IBL is approved for the rosacea and acne. It's very useful for meibomian gland dysfunction. Usually we do like 3 sessions, 1 day, and then after 15 days and 45 days. And I always do meibomian gland expression after to have better effect. It's very good, but it doesn't cover by insurance. That's the main disadvantage I found it. Regarding the other things about the blepharitis, Staphylococcus marginal hypersensitive keratitis nowadays considered one of the most common keratitis after LASIK, usually presented with peripheral corneal infiltrate in patients with coexisting blepharitis, usually multiple affecting both eyes, and sometimes really when you did the LASIK surgery for a patient and a day or two you find that this infiltrate is frightening sometimes. And really very important to examine the patient before LASIK surgery. If any blepharitis, you need to treat this one before doing the LASIK surgery because the risk of keratitis is very high. So it's very important to prevent it by treat the patient with the blepharitis before consider any refractive surgery. A special consideration in cataract surgery, always very important to ensure that ocular surface is as healthy as possible before cataract surgery. Sometimes you cannot make it 100%, but you need to improve it because as we discussed earlier, any dry eye disease and related ocular surface disorders, it will likely to be worsened because of cataract surgery. So unless you address it before and control it better, you could have more risk and more dry eye and more unhappy patient. And also, as we say earlier, that if it's filament stable, that will affect your IOL calculation, especially with the premium IOL. So surgery should be postponed until any ocular damage has been treated and resolved as much as possible. During the surgery, it's very important to protect the corneal surface. It's very good habit to use viscoat to coat the cornea during the surgery. Use preservative-free anesthetic drops. Avoid the one which is causing more toxicity like tetracaine anesthetic. The speculum you need to open just enough, not to stretch too much because that will cause lack of thalamus and exposure keratopathy post-surgery. Take home message, important to have good ocular surface assessment before all refractive surgery. Many new tests available to assess dry eye disease, but really most important really clinical examination and 1 drop of fluorescein will help you a lot to see the tear breakup time and to assess if there's any staining. Educate the patient about ocular surface disease and mention to him that refractive surgery will make it worse initially. It will take some time to settle and we need to treat it more after the surgery. Avoid laser vision correction and premium IOL in any patient with moderate to severe dry eye. Dry eye is very common after laser vision correction. It's more in LASIK, smile slightly less, and bear care lesser, but majority of them all improve within 1 year. Very, very rare people can have permanent dry eye after laser vision correction. Dry eye occur after cataract surgery, but the majority they heal very quicker within a few months. Important to treat dry eye before, after surgery, as affected patient satisfaction and the visual result. Inflammation, as we say, is play important role in dry eye, pre and post operative, and need to be treated. Avoid preservative, as we discussed earlier, because really we shouldn't have any preservative as much as possible nowadays. And also avoid any medication that can cause toxicity to ocular surface. That maxitrol, the problem that the antibiotic is more toxic to the surface, and there's a preservative, so you had more toxicity. So always try to use preservative free and maybe using separate antibiotic and the steroid than to use the combination. And thank you very much.
Thank you, Dr. Osama Yedi. We will take the question afterwards. So next speaker will be Al Ansari, which is a rheumatologist. So we badly need rheumatologists when we talk about dry eyes. And let's see what he says to suggest us. Please, Dr. Al Ansari, if you can.
Yeah.
Okay. Can you share the?
Yeah, I'll share the thing. It slides again.
Yeah. Thank you. Very well.
Something good happened. Is it visible?
Yes, it's visible. You can
Yes.
you can put in presentation. Maybe okay. It's okay.
Yes.
Perfect.
Many thanks for the organizer to ask me to come and talk here, which I think there is always a bridge between subspecialties. Particularly rheumatologists, we deal usually with multisystemic disease, and I just had been in a conference again with asthma people, respiratory. But when it comes to the eye, we have more in common in more than one front, let me say. When arthritis comes in with eye problems, the first part we usually have the uveitis. We have been collaborating and sharing a lot of stages in terms of uveitis. But there are other areas of eye disease which we need to look at. Dry eyes is one of them, as well as there are all aspects of eye problems could be in relation to either rheumatic diseases or rheumatic treatment sometime. Even retinal vascular occlusion could come with antiphospholipid or lupus sometime. So when you have a red eye, I don't know this is dry eye or this is uveitis eye. For me, I don't have the tools to differentiate. And that's why we need ophthalmology help as well as they need our referral. And we need from the other end also they be aware of the rheumatic diseases. So when it comes to the algorithm of a dry eye, all respectable speakers talked about so many different ones. But this part is what I can talk about it. And we raise awareness between ophthalmologists and rheumatologists and how to share this common ground between us. So if we come to the, let me say, diagram of what is Sjogren syndrome, there is a primary and secondary Sjogren syndrome. It's a multisystemic disease, can affect many parts of the body. And what is in common with you is the dry eyes. On the dry eyes, we used to, when I was in UK, we used to measure it by Sherman test, only because referral to ophthalmologists would take ages. While when I came to UAE, I found people seeing ophthalmologists on the same day seeing rheumatologists. So I stopped doing it. Plus, it is not that for sometimes accurate or indicative. But what is more important as well in Sjogren is the other glandular disease and parotid gland, dental problems, they do occur more with dry mouth. And I refer to Dr. Osama, who mentioned in his questionnaire, he asked about dry mouth, which is very good to do. Plus, this is explore a disease that could be mistaken. People have aches and pains, and they are inflammatory in nature, but tend to think they are ordinary type of pains. So this is a lady I just saw last week, a lady similar to this one with extensive parotid gland who had a biopsy and showed some lymphocytic infiltrate compatible with sarcoidosis. She does have dry eyes, but I did not measure it. She is taking drops for her eyes. What we see on the biopsy is the glandular nature of the disease is lymphocytic infiltrate. There are a lot of subtypes of lymphocytes, and histopathologist can give us another lecture on how to differentiate Sjogren disease from other infiltrative disease. We have sarcoidosis, we have IgG4 disease, and these are all maybe a difficult name for you just to let me say, to differentiate between them. It's difficult for us as well. So when it comes to the pathophysiology of Sjogren syndrome, it is a genetic susceptibility. The T cell play a major role in what we call SS, meaning Sjogren syndrome. I'll come to that later. Also, B cell also play a big part in Sjogren syndrome. This syndrome is specifically recognized in having high gamma globulin levels, cryoglobulin sometimes, and a lot of antibodies. Plus, epithelial cell play a role, and this is what we call either a glandular or even at what we call the eye level, there are epithelial cells could be inflamed one way or another. So when it comes to these autoantibody markers, this is a difficult slide for you to really absorb it from the first one. These antibodies could come in abundance. We try to look at the preponderance of any type of antibodies. Anti-Rho and anti-La, these are specifically for Sjogren syndrome. If they are the highest in the ENA panels, then we tend to think this patient is more classified as Sjogren. While if there are other antibodies, we could say they are more of rheumatoid or lupus or scleroderma, for example. These conditions, as you will see at the end, these are not having a clear border between them. We might have joint symptoms like rheumatoid, but a dry eyes, a dry mouth. If they are with anti-Rho, anti-La, we call them Sjogren syndrome. If they are without, we just call them rheumatoid with a dry eye and dry mouth. So the differentiation between these conditions cannot be separated. So you have patient could be labeled as lupus, but have a dry eye or dry mouth. You have patient have scleroderma, have a dry eye, dry mouth. So it is up to the rheumatologist to put the clinical presentation, phenotype, antibody screen, all in one to decide which label represent the nearest to the diagnostic or classification criteria of that particular condition. There are some treatment differences, obviously. That's why it's important to see it that way. So, what is the correlation of anti-Rho, anti-La? This is occur in younger age group, so most of dry eyes in older age group, but for younger age group with dry eye, dry mouth, you need to think about autoimmune disease. Also longer disease duration. I mean, people, when they come on, they say, I have dry eyes, dry mouth for 7, 10 years, whatever. And that's correlated with anti-Rho, anti-La antibody. Again, other exocrine dysfunction, parotid enlargement, other lymphocytic infiltrates, and other extragranular manifestation. Why we need to know about Sjogren if you see someone in your clinic? Because there are aspects of the disease could be treatable, and you could add to the improved quality of life. You improve the quality of life with the eye drops, we improve quality of life in dealing with other elements of the disease. So if we come to the American College for Rheumatology in 2012, they put 3 elements and put them together in how we diagnose Sjogren syndrome. The important one, immunological antibody, is anti-Rho and anti-La antibody, as you say, but they might well have rheumatoid factor or anti-nuclear as well. So having rheumatoid factor does not mean it's rheumatoid arthritis. Having antinuclear factor does not mean it's lupus. It's up to us to make the classification. And the second one is salivary gland biopsy. Biopsy is well recommended in a practical one. Patients, they don't like it, but it can be informative in showing lymphocytic infiltrates. And the other one is keratoconjunctivitis sicca, or ocular staining score. That's what preferred, the professor said earlier. As I said, I become lazy in doing Schirmer tests because people can quickly see an ophthalmologist rather than live in UK. So these are the three important elements to diagnose someone with Sjogren's syndrome. Right, as I said, it coexists with other autoimmune disease, not only the rheumatic diseases, other autoimmunes like Hashimoto's and Graves' disease could coexist with dry eyes or secondary Sjogren. And this is an example. This is still, there is some shining tongue, but they can be totally dry without any shining at all. And that is an important part when we talk about Sjogren. We always ask this dual question, the eye and the mouth together at the same time. So rheumatoid arthritis, if we take it, is mainly affecting the joints before it starts affecting other organs. And could affect the lung, could affect the even kidney, and could affect the eye. Again, dry eye is there, and there are a lot of systemic general symptoms. So that one is primarily rheumatoid with a lot of joint symptoms. Then we go that way in classifying it rheumatoid arthritis, but secondary Sjogren, that when it comes as description. It is still Sjogren, but we call this secondary one compared to the primary one we described earlier. So the eye symptoms that lead to a bad quality of life are significant in people with rheumatoid arthritis. So it's not only the joint symptoms. There are the fatigue and the depression and so many other symptoms, but the dry eye, dry mouth comes up a lot in the questionnaire. So we probably ought to refer every rheumatoid arthritis patient to the ophthalmologist for further assessment and evaluation. Right. Does it come late in the disease of rheumatoid disease? It comes rather late, yes, but even when we think we have rheumatoid arthritis under control, they can still develop eye symptoms. And that is, again, is there any inflammatory changes in the, let me say, ocular surface of the eye? That is the new postulation or theory being circulated. In rheumatoid, there are other symptoms like scleritis, keratitis. We are not talking about this in today. Uveitis is one of the major arm of collaboration, but the dry eyes is more increasingly so. So this is the just model about what is going on. There are a lot of immune-mediated cells, cytokine-mediated cells go around the cornea, and they have the local inflammation. So dry eyes, by description, there are inflammatory changes. We cannot measure it clinically, but it is there. So inflammation now represents the new word combined to the word of a chronic dry eye, provided that you exclude any other topical reasons from in your clinic. For example, including medication, including some other local reasons. If you could eliminate those, then we talk about chronic dry eye, and it is inflammatory condition. So when it comes to medication, there are many, but what is important for me as a rheumatologist, because we do sometimes prescribe antidepressant to our patients, and also sometimes we prescribe antihistamines. So these are the ones to blame. You need to say, oh, Dr. Athir, why you are prescribing those? But the other ones is not my fault. It's some other specialty prescriber. And this is, again, another model in how we, between inflammation, between irritation, between, let me say, organ damage. We talk about organ damage in our descriptives, but here is tear deficiency instability is the organ damage. So inflammation, organ damage, trigger factor, these are the three. It's a model in most rheumatic diseases. So it is applying here as well. Last Schirmer disease, I said, I'm not using it anymore, become lazy, but Professor mentioned it. I understand it's not very reliable and not very diagnostic. Right. Systemic therapy. Now, most of you would think if we diagnose Sjogren's syndrome, think life is rosy, that I can get treatment and all treated. It's not that true. We, over the years, as a rheumatologist group, prescribed so many systemic immunosuppressive therapies of different nature. The problem with the glandular disease or extra articular disease, they don't respond the same as they have joint symptoms. Joint symptoms, we can clear it in the best way possible. When it comes to dry eye, dry mouth, there is a general sense of failure. All these medicines tried, we could try it in a severe disease. There is only one study with infliximab, which is anti-TNF group. They tend to think they have some percentage of response or minimizing the symptoms of dry eye, dry mouth. However, that has not been seen as a protocol for a practice. We are not giving these anti-TNFs for dry eye. We give it for uveitis, fair enough. We give it even for retinitis sometimes, but not for dry eye. So we are still short of giving you a miraculous treatment, which I think perhaps miraculous treatment coming your way because you have the new type of eye drops could minimize the inflammation in the eye. What is here, this is an opportunity to discuss with you opening a channel of cross-referral. This is a model, ophthalmologists in Mediclinic, they all contributed to this, is about spondyloarthritis type of disease when they are associated with colitis, uveitis, and psoriasis. Now we distribute this paper to all of our patients in the clinic, try to increase the awareness of seeing the other specialty with the symptom. This is a model perhaps everyone could like utilize, could try to create it locally, and to establish a pathway of how these dry eyes, as long as you exclude a local eye disease, you might think of possibility of a chronic inflammation being chronic eye disease, then how you apply a pathway that to see a rheumatologist as well. Now we have the word of mouth between us, one refer to each other, but when we establish it this way, then it becomes an automatic process. So in summary, and I'm not ophthalmologist, I'm just putting these general lines, which I think you are the best to do it, of course, and just eliminate etiological factors, and then you put the lubricants on all types of eye drops for that. Immune therapy, as I said, there is now the local topical immune therapy. Systemic immune therapy yet to get established to treat a disease. However, it might help disease. It might help disease in other aspects. So that's still important that you do refer the patient. And I think collaborative and multidisciplinary work together is to find the best way to improve the quality of life for those patients. I am sticking to my 20 minutes, and I just put enough a slide for that. I can talk another hour, but that's enough for the day. Thank you very much.
Thank you, Dr. Al-Nassari. That was very instructive and I think a very helpful presentation. I think now it's my time to talk a little bit about the inflammation in dry eye. I don't know if you can see my presentation. Let's see. Okay. Okay. Very good. I will go very quickly through the concept of inflammation in dry eyes and think about a little bit about therapy that we can use. And of course, the ocular surface system homeostasis it's an effect of equilibrium. You have a continuous stimulation, and you have a continuous adaptation to the stimuli in order for the ocular surface to survive and do its work. And this happens through a mechanism that we call para-inflammation, which is an activation of part of the inflammatory cascades to have a better reaction. And if this is working, we have the ocular surface system adapted to the stimuli. If the stimuli are too strong, there is not such an ability to compensate and you get the disease. But sometimes you can compensate for time and time and time to the stimuli, but something happens that repeating the stimuli for a long time, days and days and months, will break up your ability to adapt. And we go to the concept of hormesis. And the hormesis is our ability to react by increasing the performance of the organism. And what happened in the ocular surface, we have a stress, maybe a strong wind. We increase tear production, we increase the blinking rate, increase secretion of mucins and movement of cells to compensate. But if the time of stress is too long, after a while, because of the increased para-inflammation, we get an increase of inflammatory agents on the ocular surface, and we start to decrease, you go into metaplasia, squamous metaplasia, because of the chronic inflammation. So we decrease mucin production, and we decrease the function of the cold receptors and of the nerves. So we get decreased tear production. And we know very well that whenever the tear breaks up, we have instability of the tear, so loss of the lipid covering of the ocular surface, high evaporation rate. We have a hot spot of evaporation, and then there we are having a very high hot spot of hyperosmolarity. And in the same place, we are going to have a stimulation of the nerves. And we also know that if you have overstimulation in an hyperosmotic environment, we have the transformation of cold receptors in nociceptors, in receptors of pain. So the cooling of the surface is received by the patient as pain. And of course, this mechanism is repeated and repeated. We have a shift toward hyperosmolarity, chronic hyperosmolarity of the surface, and we know the hyperosmolarity can induce inflammation, but also nerve hyperactivity, because the nerves are able to deliver some activators of inflammation. They will get neurogenic inflammation. So the ocular surface will become inflamed. You see here some kind of way of showing how the repeated stimuli will provide para-inflammation recovery of the homeostasis, but the para-inflammation is made by a number of activator of the immune response, especially macrophages, that will accumulate on the surface of the eye and induce a real inflammation. And you see here the vicious circle of the eye, or dry eye, which is more than a circle, is a spiral. And when the system breaks, you enter in the circle. And it's very important, I've been talking before, tear film clearance, because the tears, if you have a low level of production, tend to accumulate. If you have a tears full of pro-inflammatory cytokines, all the cytokines will stay longer on the ocular surface, and here you get the staining, you see, mostly on the nasal side, because it's the side where you have the highest concentration of toxic products in the tears. And we have been talking of this before. We can have the passage from what is an innate natural immunity, which has no memory, because of the activation of antigen-presenting cells on the ocular surface, because of this repeated para-inflammatory excitement of the surface, you may go into an adaptive immunity with memory, which is a completely different patient. So we have this patient with a normal insufficient tear film, which has a low clearance and higher evaporation rate of the fluid, and you get increased hyperosmolarity and increased stimulation of the nerves. You get continuously ocular irritation, which go together with an increase of cytokines, and you get inflammation. If you have local or systemic risk factor, you can get immunomediated inflammation on the eye. So you see the three yellow conditions indicate three different kinds of patients that we have. And of course, I've been telling before that lissamine green staining can be a very useful system to suspect at least inflammation. Of course, hyperemia is a good one. Chronic pain is a sign of inflammation, and you can do a lot of things like impression cytology, confocal microscopy. You can also do some tear analysis. You see this patient is the one that we talked before. You see staining of the conjunctiva by lissamine green, and you see this patient with a lot of inflammation on the surface, which this inflammation is possibly aggravated by the use of puncture plugs in this specific patient. So this is very useful. Of course, you can use a test for metalloproteinase 9. It's called inflammatory, and the previous talker has been talking about that. And of course, always remember what we have to treat. We have to treat instability of the tears, inflammation, and epithelial damage. This happens in all the patients that we see. And this is what we are going to treat. And as a matter of fact, the introduction of anti-inflammatory treatment is provided by the Deuce dry eye workshop as a second step in the treatment, and it just deduces always suggesting that anti-inflammatory therapy should start as soon as lubricants are not enough. So if you see conjunctival staining, please start think about using anti-inflammatory drugs for your patient. And of course, what we as an ophthalmology love corticosteroids, because you give the corticosteroids, you see the effect very, very quickly. But maybe corticosteroids, the available corticosteroids maybe are not the perfect treatment for our patient for dry eye, because dry eye in anti-inflammatory treatment cannot be short. You have to treat this patient for a long time with anti-inflammatory agents. So that's a risk of using corticosteroids. Well, when we use cyclosporinase, cyclosporinase needs time. So because cyclosporinase will interrupt the recruitment of T lymphocytes on the ocular surface. But at the concentration that we use, you are not going to have such an effect on the already existing activated T cells. So if you want to use cyclosporin, you have to wait some time to see the effect. And as a matter of fact, there was a group in the United States that suggested that you can use mild steroids and cyclosporin together for a while, and after 6 weeks, you stop the steroids and go on with cyclosporin. There is another possibility that we have, which is very clever, because we know that for the adaptation, inflammation is a good thing. What we don't want to have is too much inflammation or to have a chronic inflammation. So lifitegrast will stop the binding of a specific receptor of T cells on the immunoadhesion molecules. And when we have some kind of inflammation, there is a message to the epithelium or to the blood, to the endothelium of the vessel, to expose the the adhesion molecules on the surface. So these molecules will block the lymphocytes, and the lymphocyte will enter in the area of inflammation. So this will transform an acute inflammation into a chronic inflammation. And if you can interrupt this and stop the, adhesion to the ICAM1, to the adhesion molecules, the T lymphocytes are not recruited on the surface. So your inflammation will do its work of adaptation and then will stop. This is a very interesting approach. And unfortunately, the drug is not available in Europe yet, but we hope for the future. And but the idea is very clever, and I think it's very interesting process. So closing, please think the importance of inflammation in dry eye disease, because inflammation is what is maintaining the dry eye on the surface. Dry eye is not just a problem of tears. And so don't be afraid to start anti-inflammatory treatment quick during the patient. Then you can think of stopping it if everything goes well. Otherwise, you have to shift to something that you can give for a long time. So let me thank you for being with me in this evening, and I think we can accept some, some kind of question if available. Let me see if I think there are some questions already in the mark. So please write down your question if you have. We have some question for Dr. Osama. The question is about how to detect inflammation in dry eyes and which kind of anti-inflammatory drug you use after surgeries.
So basically, to detect inflammation, staining is one of the crucial. Any conjunctival or corneal staining, this is a sign of inflammation. If you had MBB9, that's very useful also, and the osmolarity. That's the three things which are very useful to detect inflammation. But also when you examine the patient, red eye, symptomatic, that's also a sign of inflammation. Regarding the medication, as we know, using usually steroid, all of us for the first 2 weeks, 3 weeks. But after that, I'm using either cyclosporine or lifitegrast as anti-inflammatory when the dry is not controlled with artificial tear alone. Professor, I cannot hear you.
Thank you. There is a question about the filamentary keratitis in dry eye. Is Dr. Omnia, would you like to talk about that or not?
No, I'll keep it for you actually about
Thank you.
the cornea, for the cornea treatment.
Well, let's see if I can address the question. Well, filamentary keratitis. It's really the expression of the damage of the ocular surface. Filamentary keratitis, it's a damage of the epithelium, and it's a damage also of the deep part of the epithelium, but because many of the filaments are starting from Bowman layer. So it's a severe damage of the epithelium. And if you have a filamentary keratitis, the first thing that you have to do is to remove the filaments. Otherwise, you are in trouble, and your patient is more in trouble than you. And then remove the filaments and use something very viscous to protect the surface. My step, whenever I can, I put anti-inflammatory therapy on the surface of the eye. I use steroids in that case because I want acutely depress the inflammation of the surface. I use a kind of viscous aqueous tear substitute, and many times I use silicone lenses. I mix the silicone hydrogel lenses on these eyes, and I keep them for 7 days. I do. I'm not sure if it's correct, but I do prefer in this patient to put a drop antibiotic on that because I'm very scared about abscess on the cornea, and I give the possibility to the ocular surface to rebuild an epithelium. This is severe dry eye, and you have to plan your long-term treatment for your dry eye, which will be an anti-inflammatory drug and a lot of lubrication.
We see some patients who try to fish actually and remove those secretions with their hands or with some tissues, and I don't know if it's the same kind. I think so, of the inflammation, no? Let's make it worse.
Yeah. This is an interesting aspect. It's not just what we call filamentary keratitis, but it's like what is being called mucus fishing syndrome. Mm-hmm. It is exactly what the young patients are doing, and this you have the opportunity of doing a very good diagnosis to the patient and impress the patient, because many of these, they have ovarian problems. Mm. Yeah, these patients are ladies in their 30s, 40s, and they have a lot of hormonal problems of hyperestrogens. So they remove that. This is a consequence of inflammation, but this is the kind of lack of fluidity of the mucins is typical of hormonal problems. So you say to the patient, do you have some ovarian cysts? And they say, oh, how can you tell me that? Because it's very frequent. So,
Interesting.
But it's always think hormones.
Yeah.
I add for filamentary, one thing I add, if you had the acetylcysteine, the drops that also help to dissolve this filament to not to reform again.
Yes, I agree. Acetylcysteine is very useful. Yeah, thank you. So let's see. Well, there is a question about when do I add? Well, there is a question for Dr. Athir, and do you have the same approach for dry eye and uveitis?
Yeah, thank you for the question. The issue of dry eye is between two subspecialties compared to uveitis, between 4 subspecialties. When dermatologists cannot use to refer patients, gastroenterologists, they are not aware of any uveitis happen at the same time. So it was a big problem. I had to bring them together and to agree on this. With the dry eye so far, I didn't feel that much need. All the excellent ophthalmologists, Dr. Raif, Dr. Osman, Dr. Huda, all that I take on the phone, I say, look, I have a dry eye, and they send them. However, this is only half of the solution. The other half is the patient might not come at the end. When we give them a piece of paper, it increases awareness, retain it in their mind, like these are linked together. If they don't come on that referral, they will come later. So that's the benefit of let me say, information sheet or something like that. It's good that when we finish with that project just a few months back, let me think of this one. I'll take your view on this and I'll work on it.
We cannot hear you, Professor. We can't hear you.
Sorry, okay. There's a question about omega-3 tablets and the use in dry eye. It's anybody of you has some, hints about that?
I think it's omega-3. It's some patients they benefit, but although 2 to 3 years now, DREAM studies show that studies was compared olive oil and omega-3, but both the group they improve it. So that study may supported that olive oil also good also on top of the omega-3. But I think it's useful in some patients.
Yes, because coming from Italy, I must tell olive oil is very good, and but yeah, I'm sorry, I'm been involved in the first paper who has been talking about taking high levels for omega-3, and there was a little bit of omega-6, and we showed a decrease in the amount of pro-inflammatory cytokines, HLA-DR, on the surface of the eye. Well, it depends, I think, from patient to patient. I completely agree. I don't know if there is any more scientific answer about the matter.
No, but some patients, they ask about it, actually. I have some patients, they ask me, but actually I don't have any experience with the omega-3.
Yeah. Okay. There is a question now about non-steroidal, and maybe if you, Dr. Ghiredi, if you want to, do you use non-steroidal?
Personally, I don't use them really for dry eye. I use the steroid or go to cyclosporine lefitograph. I don't use non-steroidal as an option for me.
Okay,
I'm not sure what you think.
Yeah, I'm using the non-steroidal anti-inflammatory for the patient post-op and even to prepare their ocular surface for the surgery. But actually, I was planning to ask you this question because you keep talking about the steroids and the cyclosporine, the immunomodulatory, but you never talk, both of you, during this meeting about the non-steroidal anti-inflammatory, while I'm using it actually for all my patients to prepare them for the surgeries.
Okay. Well, non-steroidal have a bad reputation in ocular surface because they are cytotoxic. Most of them are directly cytotoxic. Mm-hmm. And many years ago, at the beginning of the use of non-steroidal, there was a big problem with non-steroidals in the fact that there was some epidemic of cornea melting in patients using non-steroidals. And what came out that all these patients had a high level of metalloproteinase 9 on the surface. And so MMP9 is a risk factor for the use of non-steroidals. And what happens that MMP9 is very frequent in the ocular surface of patients with dry eye. So non-steroidal, for what we know now, have not to be used chronically in patients with dry eye because it's a little bit risky. I'm not sure that a short term of non-steroidal is very dangerous, but for a long-term therapy now it's not really approved. I don't know. I don't know of any long-term study of that, but sorry.
I'm using it for 3 months actually. Yes, approximately 3 months for the patient. So I'm giving them at the same time as well the steroids for a longer time post-op, post-surgery.
Okay.
And recently, I read an article, a study done in China. They give the patients also ibuprofen, non-steroidal anti-inflammatory tablet for the patient for 2 weeks post glaucoma surgery as well. So okay. Yeah, actually, at the end, all what we are doing as glaucoma specialists is just really to improve the ocular surface, because this is our main enemy. Yeah.
Yeah. Well, we in Europe we have a very low concentration cortisol, so hydrocortisone steroids, which I personally use after filtering procedures for a couple of months, something like that, because they have a very quick metabolism into a non-steroid metabolite, so the risk of having cataract and something is very, very low. So it's something that stays on, it's rapidly metabolized on the ocular surface, and it's an interesting possibility that we have to protect for fibrosis the filtering area.
Okay.
So, but it's okay. Start rethinking, about non-steroidal. Maybe it's useful. I don't know. Okay, my next life I will do that. Okay, it's there are other question, which is another question, which is the diagnostic test that you feel most accurate. It's anybody want to answer?
Which diagnostic test in the mouth?
The most accurate test, I think, for dry eyes or whatever.
I think the symptoms, the patient symptoms.
Well, this is the most accurate from the side of the patient. Yeah, we have the splitting in the clinic of dry eye, which one is for the feeling of the patient, the other the feeling of the doctor. And the symptoms are for the patient, and the staining is for the doctor. I very much realize, well, breakup, it's okay. If you don't have a breakup time short, you don't have a dry eye, probably. But I think staining is very useful to understand which kind of patient do you have. And then there is a discrepancy between the symptom and the staining. Please do corneal sensation testing. With a wisp of cotton and just touch a cornea. And it's very much to feel the patient that you have in front of you.
You are using Professor, you are using the Lissamine test regularly in your practice?
Yeah, I do. In each patient who is coming with some problem of the ocular surface. And it's now we have a very nice applicator which gives 12 microliter Lissamine green, and with a micropipette or something like that, but it's very practical. And it's very quick, and it gives a lot of information. Really a lot. A lot of patients, they do not have corneal staining, but they have plenty of conjunctival staining. So you recognize the patient a lot. And for checking the improvement, well, corneal staining is more rapid. You see the improvement more quickly, but you also can check the improvement with your treatment with the Lissamine green staining. But also, if it's going to be confirmed, the idea that Lissamine green staining is reflecting the level of inflammation, if this is going to be confirmed, this will be very, very useful in the clinic.
Recently, I had two patients. Glaucoma patients, newly diagnosed, and they are on medication since 6 months approximately. And both of them, I found superior limbus keratitis, and they are complaining severely from the irritation. While I put them on preservative-free prostaglandin. So both of them females, and I tested also the thyroid functional test. They are okay.
It's 11 o'clock.
What's your advice? What can I do more for such patients?
I would put them in Diamox and remove everything if I can, and give them a short 10 days of steroids. Yeah, you have to be wild. I mean, in this, because you know, you have to decrease the inflammation because it's an inflammatory disease that. And you have to decrease the inflammation, and then you go to a mild. I am an expert in dilution of steroids, but don't tell the companies. But I prepare steroids, very diluted steroids, because sometimes my patient will stay much better with steroids, which is 1 in 25. I think very little concentrations. So
I started them on steroid actually and lubricant. And I was planning to do for them SLT, but I was still thinking if I can do something more, or if they have any other problem, not related to the anti-glaucoma agent. Yeah,
well, I find a very strong correlation with the Sjögren's syndrome patient and that presentation. And thyroid, of course. Thyroid disease and But you know, there is this discrepancy between what we see and think is Sjögren and the rheumatologist who is going to say, well, I don't see Sjögren at all. But they don't know. But it's okay. I think they are pushing to us to go away. So let me thank you. It's been a very, very interesting meeting, and I hope to see you again around the world. And thank to Novartis for organizing this, and thank you all. Have a good night.
Thank you. Thank you, Prof. Thank you, Dr. Osama.
Thank you very much.
Thank you.
On behalf of the society, thank you to the artists and everyone. Thank you so much.
Thank you.
Thank you.
Bye-bye.